So Regorafenib, been around a little longer. Kind of give me a picture of the ideal patient that you might like to put on Regorafenib in this space, and tell me a little bit about your starting dose.
So when we look at the patients that would eventually get on Regorafenib in that line, those are patients who failed, say in the RAS wild type has failed EGFR and VEGF inhibitors and FOLFIRI and FOLFOX in the RAS mutated, a couple of chemotherapy regimens and then Bev. Those patients, are performance stats 0 and 1.
So not 1.75 really.
1.75 would be kind of okay depending. So, like Dan said, you have to individualize at the end of the day. That's what we do clinically. There's no biomarker that will help you with that. I mean, you look at the patient, you look at the numbers. So someone who has a significant hepatic dysfunction or risk of significant hepatic dysfunction, I'd be a little reluctant.
So good PS is important, I'm hearing that.
Relatively good PS for the line of therapy.
Yeah.
It's rare to see the performance status 0 at this point of time, but a performance status of 3 should not be given frankly, any agent.
Tell me about your dosing.
So the dosing, my preference outside of a clinical trial is to start with 160.
Full dose.
Full dose. Well, the reason for that is twofold. One, when you look at the progression-free survival at the median for all these regimens at this point, it's 2 months. Meaning by the first scan, you know whether the patient responded or not. And we responded, meaning that mostly stable disease. And so we have a very short window of opportunity. So to toy around with the dosage without any data that supports it makes it very difficult for me to actually start with a lower dose. If we had 6 months or 10 months to play with, I wouldn't mind actually starting with a lower dose.
Kathy, your dosing?
My dose is 120.
120?
120.
120. I used to be in Tony's camp, I have to say, but it just was really hard to give.
Yeah, I think it dissuades patients sometimes from continuing treatment if they have that bad reaction.
And I actually agree completely with, because I'm nervous every time I do that. Yeah. Am I losing my margin that I was going to get? How are we going to solve this debate that's up here?
So hopefully we have a solution coming through, hopefully. I mean, we'll see the results of the study. So we're conducting a study, a REDOS study, which essentially is looking at 2 arms. It's a large phase 2 randomized study looking at a dose escalation strategy and a standard dosing strategy. So half of the patients will be randomized to 160. The other half will be randomized to start with an 80. After a week, if no toxicity, go to 120. Then after another week, again, if no toxicity, at 160, they'll settle down on the dose that is tolerable for them. And so, this will require, as you should do in clinic, of course, is that patients will come on a weekly basis to be seen at least over the first 4 weeks, preferably also over 8 weeks. And so you'll monitor them very closely, adjust the dosages and what have you. We're about midway accrued on the study, so I'm hoping that by the end of the year we'll have some results about if that dose escalation strategy would allow us to actually induce the same benefits than with starting with 160.
Yeah,
What's the primary endpoint?
So the primary endpoint is essentially those patients that are able to get their scan at the end of 8 weeks and able to continue through.
So it's basically toxicity crossed with maintenance of the benefit.
So it's really a hybrid endpoint of some benefit and toxicity.
Yeah, I think it's really important. If you look at the label for capecitabine, it's still the same original doses, even though no one gives it. And this is sort of responsible upfront clinical trials to try and answer this really important question.
And we've never done this with sorafenib, with sunitinib. I mean, all these questions come all the time. I think this is good that we're doing it in this setting and some of that argument about these TKIs, because it's not just a Regorafenib. Any TKI, I mean, you go and ask 20 physicians how they do it. Everyone does it different.
So you all are world's experts. This drug hits 19 different targets. How's it work?
19 different targets.
19 different targets. 19 different toxicities. But the other issue is biologics. You don't know what the right dose is because the dose is usually based on the maximum you can give, not the best dose for tumor shrinkage. So for cytotoxic, like with TAS-102, the initial dose may be important because it's not like first-line therapy where you can kind of glide into it. And we learned, unfortunately, for example, with the combinations of FOLFOX with Bev and cetuximab, maybe if we had not given all 8 drugs on the first day,
Yeah, we'd have been
where
okay.
you had a car crash and then you had to stop all the drugs, it might have been better.
Yeah.
It might have been better to introduce them. But in last-line therapy, I cringe a little bit when I talk about, for example, TAS-102, people say, oh, well, I'm going to start at half dose.
Yeah.
Okay, 50% of people come off after 2 cycles. You can't ease into last-line therapy.